Dr. John Sarkaria, professor of radiation oncology at Mayo, where he runs the Translational Neuro-Oncology Lab, and he has had a major role in the national resource of the generation and characterization of GBM PDX that all of us have been using. I know he's a long-term collaborator with Forrest, but I don't see us working on mouse models without John. Please.
All right. Well, thanks, Forrest and Francisca, for inviting me to talk about some stuff that I think is really cool. I did my postdoc at Mayo and developed a kinase assay for ATM, and now we actually have drugs that can hit ATM, so it's super cool. And it's kind of a nice merging of pharmacology and radiation oncology, which are the two things I really like. I work with a lot of people, and I was told for an ASCO presentation I should have the key points first. So here are my takeaway key points. WSD is an ATM inhibitor from Weishan Biopharma. It's a very effective radiosensitizer, but as I'll talk about, careful integration with radiation therapy planning techniques, and pharmacology is really going to be important to move this forward in clinical testing. So ATM was discovered by analyzing a number of children like this. This child got a fairly low dose of radiation, 30 gray and 19 fractions with cobalt for Hodgkin's lymphoma, which she ultimately was diagnosed with ataxia-telangiectasia syndrome, which is a homozygous inactivation of ATM. And that led to this discovery of the biology of ATM, which is, a simplified version is shown here on the left, which it's really a key orchestrator of DNA damage response to ionizing radiation, especially double-strand breaks related to ATR and DNAPK as other family members, but is a central and super important pathway. And so now we have the kinase. We've identified drugs that can hit this kinase, and so essentially we're going to use a drug to cause what is happening with this child. We're going to inhibit ATM completely and give radiation there. So it's something that needs to be thought about fairly carefully. But here's just data with WSD0628. You could change the name to any other ATM inhibitor. You'd basically see the same data. On the Western blot, you can see that we're robustly inhibiting autophosphorylation of ATM that gets induced with radiation and then suppressed by about 10 to 100 nanomolar. And CAP1 is a direct phosphorylation target of ATM, and so you can see loss of CAP1 phosphorylation that's induced by radiation and suppressed by the drug. On the top right is a classic clonogenic radiation sensitizer study where 30 nanomolar has really robust radiosensitizing effects. To give you some perspective, clinically used radiosensitizers like cisplatin would be not even close to what 10 nanomolar is showing. So this is, as a radiation biologist looking at this curve, you're like, dang, that's something that's pretty rocking. And then this is, the bottom curve is really important just to understand when we give a drug to a mouse or a human, it doesn't stay at a constant level like it does in the dish. So you kind of need to understand, well, how long do I need this drug around to do its thing? And so here we dose these cells with the WSD compound and then radiate them and then wash the drug off at different times after. And so that's what you're seeing on the x-axis, the time the drug was washed off after radiation. So you can see if you wash off the drug at 4 hours versus 12 hours, there's more killing in the red line with the radiation plus WSD if the drug's on for 12 hours and so on to 16 and 24. So really kind of providing us a target. Hey, we want to maintain 30 nanomolar, the equivalent of 30 nanomolar in cell culture for 16 to 24 hours to get really nice effect in animals and in humans. And so this was a drug that was engineered to be brain penetrant. And we kind of superimposed a target based on free drug levels. But basically, you take my word for it, in that 6.5 nanomolar, that's kind of our minimal target. And with dosing, we should be able to achieve that for at least 12 hours. And then in these studies here, the A through C is 2.3 gray times 10. So this is a reasonable fractionation schedule of radiation. You can see placebos in black, radiation alone is in gray, and radiation plus drug is in red. And I would say that's a pretty kick-ass response. Like if I had a tumor and I was going to be treated, this seems like it'd be a good drug combination. But like we showed you with that child, ATM inhibitors can cause a lot of toxicity. And so we actually were having problems with our mice dying when we were giving the radiation to the brain. We figured out, well, it's just we're skimming along the top of the roof of the mouth, and they were having severe toxicity and weren't eating and losing weight. So we kind of said, well, let's kind of study that a little bit more directly. And so here we actually have a model where we're radiating the entire oral cavity of the mouse. You can see that yellowed out areas where the radiation beam is coming in. The upper and lower incisors are shown in white there. So we're radiating that entire oral cavity, and on the bottom there, we're basically giving the radiation and then weighing the mice daily after radiation. And a week after radiation, they get this essentially a sunburn on the inside of their mouth, and they stop eating and drinking, lose weight, and if they lose more than 20% of their body weight, then we euthanize them. So you can see with 3 fractions of 5 gray, the blue lines, the mice are fine. They don't lose any weight. This is exactly what we'd expect from human experience as well. When we double up and go 3 fractions of 10 gray, they all get sick and have to be euthanized. And then with the lower dose of radiation plus drug, yeah, they get sick. And you can see that what happens in the middle there with the H&E, where you have a nice stratified epithelium on the top, but with the drug plus radiation, you lose that epithelial covering of the mucosa. And the dose response is quite dramatic. This is a plot where each dot represents 5 mice that are radiated, and we're measuring how many of those have significant body weight loss. And so you can plot this and kind of figure out like what dose of drug causes what kind of change in toxicity. And the notable thing to say is, well, okay, with no drug, the dark blue line, it takes about 27 gray and 3 fractions to give this severe body weight loss that requires euthanasia. Whereas when you're at 5 milligrams per kilogram or 7.5 milligrams per kilogram, you only need around 7 or 10 gray of radiation. That's a dramatic difference. When we think about in the clinic, we're going to do this, that could be a significant toxicity. So, you know, I think it's interesting. We see a fairly similar dose-response relationship to improve survival in the animals. So this is an orthotopic GBM model, and we're dosing the mice with drug just before a single 8 gray fraction of radiation. And similarly, you know, like at 2.5 milligrams per kilogram, we're seeing a doubling in survival with radiation. That's pretty good. That's pretty similar to what we were seeing with the oral mucosa. So that gets us to this dilemma. We have the best radiosensitizer I've ever seen. Any ATM inhibitor, it's not just WSD. But you have a lot of risk. And so how do you balance the risk versus the benefit? And that's really kind of what I want to talk to you about today. So first, when we're thinking about just generically developing a radiosensitizer, it better be worth it. If you're going to take the risk of being like that child, it better be worth it. And so in recurrent GBM, we saw earlier today, the risk of death is about 50% at 6 months, and it's almost universal by a year. So that's pretty worth it, especially when you're in your mid-40s or mid-50s in recurrent GBM. Yeah, I'll take that risk. But then how do you minimize that risk? And part of the thing that we really want to figure out is what do we need to radiate? Defining exactly what to radiate is super important. So we've done a lot of studies with MRI compared to F-dopa PET, which is a large amino acid that's taken up. It's FDA approved for Parkinson's disease imaging, but also useful for GBM. And you can see the MRI scan is on the far left, and let's see if I can find this. And then this is the F-dopa PET scan. And a lot of times we use the contrast enhancement to define where the tumor is. But you can see in this example in recurrent GBM, there's a lot of tumor that's lighting up outside that contrast enhancement. And this is just a summary of 20 patients we did on a trial. The yellow is the overlap between those two signals. So one imaging modality is not enough. I think so if we really want to define our tumor better, we better use both. And really just to illustrate this point, I imagine there's not many radiation oncologists in the room, so I thought I'd go over like, hey, how do we use this? So in newly diagnosed GBM patients, we typically would just use, historically have used just the MRI, and we'd outline, as shown in blue here, where the contrast enhancement is. And one thing that's notable is there's some regions that are really bright and easy to see, and there's what we call wispy enhancement, which is pretty wimpy. And then we'd expand that volume by 1 to 2 centimeters, and we'd have this as our target. And if we did that without thinking about the PET scan, there's some areas that are, they're not the greatest, but it's pretty good. Well, as a physician, pretty good is not good enough. And certainly if you were a patient and you said, well, it's pretty good, that's not going to really go over very well. We really want to know where it is exactly. It becomes really important for recurrent disease. These patients have already gotten 6-degree of radiation, and so we're very tight on our margin. So if we're using contrast, we're just expanding by a couple millimeters and going to target that region. Well, you can see, like, if we just did the MRI in this patient, we would miss a lot of tumor. And there's no surprise here. If you treat half the tumor is not going to do any good. The tumor's coming right back. And so targeting is very important. The reason that targeting is important is that we're defining our target. Okay, we've used both imaging modalities. We've defined our target. But then we develop our radiation plan. And this patient here, standard plan, we'd bring an arc. We'd come from the front and bring that machine and come over to the side. And then we'd come with a mohawk and come up over the top. And that's going to, X-rays go through and through, right? And we're having the high dose region here where we outline the target, but there's this lower dose wash that is just not particularly useful. We're really potentially more toxicity. And you can see from that mohawk beam, we're having dose that comes into the optic nerve. And so just to kind of tell you how we think about this is a very small portion of our prescription for radiation therapy. And we define various parameters about here's how much dose we want to the target, how much we're willing to accept it, not get exactly the dose that we prescribed. But then we also talk about normal tissues. And we said, okay, well, this region around the optic nerve, we want it to be less than 20 gray and less than 25 gray on the right side and the left side. And you can see, oh, dang, here we're well above our target. We accepted this plan because, maybe we're going to be on this optic nerve a little bit high, so the risk is is somewhat high that we'll have blindness in one eye, but this other eye is well below our target. So unilateral blindness is a risk that we're willing to take. It's not a given, but we got to accept that risk. But you think about it, as you add in a radiosensitizer like an ATM inhibitor, what is that risk? Without the radiosensitizer, we have decades of experience. We understand that risk very well. With an ATM inhibitor, we don't understand that risk very well. And so there we're thinking, well, maybe there's a different strategy we can use. If this is our target volume, is there a way to do this better? And it's really kind of goes to radiosurgery type techniques. As we bring more and more beams in, we can spread the low dose out better and have a much tighter high dose region and limit the normal tissue that's going to be exposed to radiation. And that, I think, is going to be one of the important things as we think about just generally these really potent radiosensitizers is doing a better job. And so I think these are known risks. That we know this is going to be a problem. There's definitely strategies that we can use to take care of this. I think I've seen several clinical trials with very potent radiosensitizers that did not think about this, and they failed. They were unable to achieve clinically meaningful concentrations of drug, and those drugs were discontinued with external beam radiation. So I think kind of thinking this through is super important. Anyways, the data that I just presented earlier about the ATM inhibitor, that led us to this clinical trial that we're running at Mayo Clinic. It's the first in human evaluation of this ATM inhibitor in recurrent GBM. Again, we chose recurrent GBM because the risk-benefit ratio is a little bit more acceptable when we have no idea what the drug is going to do. This is a pretty standard radiation regimen that we use. The first day they're getting drug only, and then the second day they get drug plus radiation, and they go on for 10 days of radiation. We're right now in the dose escalation cohort, and then we'll talk about one thing, and we'll talk about tomorrow is the tumor penetrance cohort and how that could play into some of the work that we're doing, because there we're going to give drug and radiation and then harvest the tumor with Ian's help. So just a schematic again for the non-drug developers. Generally what we do is we start out with a dose of drug that we think is going to be completely safe, but we also think it's probably not going to be that useful. So we want to escalate through these low doses and get up to higher doses where we think we're going to be more effective. And so far we've accrued on these 3 dose levels, and we just opened to this dose level here. But the question is, like, if I do a really good job as a radiation oncologist and I don't have a lot of toxicity because I'm avoiding the skin and other mucosal sites and stuff like that, the drug inhibiting ATM should be very well tolerated for a short term. These children grow up, they have some problems, but for several years of life, they have no symptoms. So 2 weeks of inhibition of ATM should be completely well tolerated for on-target drug effect. So what's the effective drug dose level? How do you think about doing that? Part of it is like, okay, yeah, if we run into really bad toxicities, that's something that tells us we can't go any higher. But these are going to be toxicities from most likely off-target effects of the drug. And so in this case, we've had one patient with liver enzymes elevated, and then one patient with some cerebral edema that increased, but they had a rapidly progressive tumor. This happened early on in the course, so we think that was not drug-related. But I think kind of what we think is going to be useful is looking at the pharmacokinetics in the plasma, and then correlating that with the pharmacokinetics that we get in our animal models. And so the only take home here is that this looks like a real drug. It has a half-life that's on the order of several hours, so we should be able to maintain inhibition for several hours after radiation. That window of 16 to 24 hours is probably realistic with even a single dose of drug, but if we had to, we could give a second dose of drug 5-6 hours after the radiation. But this is what I wanted to really think about. If you remember that one graph I showed where we were looking at the efficacy extension with radiation in the orthotopic tumors, and this is the plasma profile that we were looking at. 1 mg per kg wasn't very effective. 2.5 mg per kg was pretty effective. 5 and 10 was even more effective. So that kind of says, okay, in the mouse, the free drug levels in the plasma, we probably want to be, just empirically, we'd say we want to be right here. And in the tumor, we understand partitioning into tumor, so we could say this is what we measured in the tumor in those mice. It all makes sense. 1 mg per kg didn't work, 2.5 did. If we take this now and just put it over on the human data, where are we? And so we're not quite there yet, right? These are the different dose levels, 5 milligrams, 10 milligrams, and 20 milligrams in patients. We're starting to get close to the target, but we really want to be above that. We probably want to be a log higher in plasma concentration. So, we're thinking like, yeah, we may be getting there, but we're actually amending the protocol to go higher than that original dose escalation that I'd shown, just because I'm nervous that, will we get, have a reasonable duration? I'd like to get something like this, like 5 or 10 mg per kg exposure in humans, so we clearly need to go higher. But, we have an interesting anecdotal response. We all get to show the anecdotal, hey, this looked awesome. This was a patient with recurrent GBM. We gave radiation plus drug. She had a really nice response, regression at 1 month, and even more impressive at 3 months. And if we really hadn't thought about the pharmacokinetics and didn't measure the pharmacokinetics, you know, the unbound tumor concentration is a little bit low, you know, but if we look at total drug concentrations, our maximum drug concentration, not shown here, is above our target, is above like what the IC50. So if we were just saying, hey, what's the IC50 in cell culture and what do we achieve in humans, we'd be like high-fiving all over, like, yeah, this is awesome. But if we start thinking about, okay, well, in our animal models, we needed this unbound concentration that's kind of in that 10 to 100 nanomolar range. We're just not there. And so this is probably, even though unusual, just a really awesome result from radiation only. And I think it kind of illustrates the importance of thinking about this and modeling that a little bit more carefully about the pharmacokinetics. So just in general for this clinical trial, we're continuing our dose expansion. Like I said, we're going to add a few more dose levels. Then once we identify an effective dose level, we'll go to include patients that are going to the OR for resection. They'll get the drug, then they'll get gamma knife radiosurgery, and then we'll resect the tumor so we can look at both drug levels in the tumor, but also look at some of the pharmacodynamic markers for target inhibition. One of the strong reasons why we included gamma knife in this, which is not our standard of care at Mayo Clinic, is we felt that the patients needed to have some benefit. And just getting an ATM inhibitor and that's it in a surgery really provides no benefit to those patients. Whereas the gamma knife, you know, the high dose region is going to be resected anyways as part of the resection, but potentially that low dose bath there's going to be some low dose from the gamma knife, and would we, you know, have some benefit there for those patients? And then we have plans to expand this into newly diagnosed once we, you know, are comfortable that it's reasonably safe. And that's all I got to say. Thanks so much.
Thank you, John.
So if you amend the protocol to go higher in the dose escalation, so now you have 3 patients with grade 3 or larger toxicity, that's just going to go up, right? How will we manage that?
So I didn't catch the...
You said you want to amend the protocol to, right, go higher in the dose.
Yeah.
And so for the patients that you've dosed now, we have 3 grade 3 or 4 toxicities, right?
Yeah,
that's then going to go up as well, or is there a way to circumvent, somehow vaccinate against?
So there were 3 grade 3 toxicities. 2 of them were liver enzyme elevations that happened in 1 patient. And then another was a cerebral edema that happened, we felt would have happened whether they got radiation or not. They were rapidly progressive tumors, probably a patient we probably wouldn't, in retrospect, enroll in the trial just because they're not in great shape. We didn't feel those didn't meet the criteria for being dose-limiting toxicities.
Okay.
And so we're comfortable with the escalation. There's a whole schema about prioritizing how many patients are evaluated for toxicity. If they develop a toxicity, then we potentially add more patients. So there's like and then if you have toxicity at one level, then you drop down to a lower level. So it's kind of a whole system that.
Thanks.
Thanks. So, Jan, this stuff is really exciting. One question I have for you in the development of these drugs, though, and you talked about this, there's the other option for the therapeutic window would be to lower the dose of radiation, right? And so you're really dose finding to elevate the dose of the drug, but you also could potentially lower the dose of radiation. And as you and I have all seen these patients who go on to these radiosensitizing studies where the toxicity has been absolutely terrible, just like that patient that you showed. So how do you envision that? You know, that becomes a much bigger matrix of searching around for dosing in patients. How do you envision that working?
Right. Yeah, I think it's challenging to significantly dose reduce the radiation because you have the proven therapy, and there's no expectation that every patient will benefit from a novel therapy. Generally, maybe 50% of patients would benefit from a novel therapy. And so you're kind of saying, well, I'm going to roll a dice and 50-50, you're going to get a subpar therapy because you don't see sensitizing effects with the radiation that's now at a lower level. So the way I would envision it in a different way would be to say we give, there's really very few drugs that we give daily as a radiosensitizer. In, say, lung cancer is commonly given, you give chemo with radiation, but we typically give it on 1 week every 3 weeks or something like that. So there's nothing that says you have to give it a radiosensitizer every day. And so I would rather give, have a, say, a 2-week or 6-week course of radiation and give full dose of drug, if you will, 1 or 2 weeks out of, for maybe a third of those treatments, and then the other days not have drug, versus giving a low dose of the drug and have kind of subpar sensitizing effects. But that's actually stuff we were just talking with Francisca about, like, can she model that?
John, and I have one question. You showed really beautiful data in the mouse. There you showed, I think, a couple of models probably. And I was wondering how different is the response, right, from one model to another? Because going back to the issue of diversity between patients, I am sure that there are tumors that can be identified before you enroll them in the trial, potentially, that may be completely resistant to this, right?
Yeah.
Typically what we see in the lab when we treat them with radiosensitized plus radiation are the mesenchyma, right? GPM tumor, those are the most resistant. And there, I personally would not want to enroll those type of patients, right? Because I think it's the wrong therapy for them. On the other hand, right, those in the neurodevelopmental axis might be really exciting opportunities where you can also probably go down, right, with the drug, right? So have you thought about that? Have you seen anything? I know we spoke a little bit, but have you seen anything in the mice or even in the patients, right, where you may have data to correlate, right, the status of the tumor with the response?
Yeah, it's a great question. I think there's a reasonable amount of data before our lab published it, as well as something we published with another ATM inhibitor, that p53 mutation. Those tumors tend to be more sensitized with the drug, with an ATM inhibitor, with radiation. But to address that question directly, we're doing a screen with 40 different PDXs. So we'll do intracranial implantation, randomized to placebo radiation or radiation plus drug across 40 PDX models, and see what the spectrum of response is, and hopefully identify predictive biomarkers.
I would love to work with you on that.
Yeah.
That would be really exciting. Okay, fine.
Thanks. Yeah, Jen, I was just thinking about, given Natalie's talk earlier, and just thinking about sort of local delivery versus systemic delivery. And is there an option in your mind for trying to, instead of giving the ATM inhibitor sort of systemically, to try and give local delivery where you're going to irradiate?
Yeah, for sure. I mean, I think, two strategies might be, it's challenging in a GBM, but in other sites, potentially an antibody-drug conjugate or similar strategy to have a tumor-specific delivery of your radiosensitizer and to try and limit that normal tissue toxicity. Some type of depot nanoparticle formulation or what have you that would disperse drug over time. There's some challenges, obviously, of having uniform distribution of that drug throughout your tumor volume and the residence time of that drug staying in the volume. But I think those are interesting questions. I mean, radiation is inherently a local therapy. And so combining two local therapies is very reasonable. Yeah, for sure.
More questions? Please.
Thank you. I just had a question about, with the increased cell death that you're seeing in the mouse models, are you also seeing increased immunogenicity? And have you tested this with any immune therapies?
That is a great question. So we just did our first clonogenic assay with CT2A and GL261 just to see in vitro whether it's a radiosensitizer for those lines. it looks like it is, and so we're going to look at that in the syngeneic model and then talk to you guys.
Thanks, Jan. Just curious, back to the local therapy ideas. Have you thought about or used a gamma-tile approach to deliver the radiotherapy and combining it with the drug?
Yeah, we haven't. I think, yeah, just we're not a gamma-tile group. I think you could hand the microphone to Ian, and he could talk to you more about why we do or don't use gamma-tiles.
Well, we don't because you guys don't want us to. So I'm going to give it back to you. No, we've not done that. We've debated doing that. There's been, of course, various types of brachytherapy for gliomas and various flavors for a long time, 40 plus years. This is the latest flavor. We haven't pursued that, but perhaps in the context of a radiosensitizer, we could relook at that.